Next, we will have Joan Rugemalila from Tanzania, who will be talking about HIV viral suppression and patterns of drug resistance mutations among adolescents and young adults in the context of Dolutegravir, a cross-sectional study in Tanzania. Joan?
Thank you very much. Can I have the slides on, please? Okay, thank you very much. So, thank you for the opportunity to present these study findings that focused on HIV viral suppression, the patterns of drug resistance mutations, and we focused to study the group of adolescents and young adults in this context of rollout of Dolutegravir. So we all agree that HIV drug resistance remains to be a significant threat when we all look forward to achieve the effectiveness of treatment of HIV termed as ART. And so this becomes a really significant barrier when we look at achieving the UNAIDS fast track goals that are aiming to end AIDS by the year 2030. So of importance is the surveillance and knowing the drug susceptibility, either patterns or scores. That is so important to inform how best we implement the choice of effective ART. And we're aware that most of the studies, particularly in Sub-Saharan Africa, have already reported that there are higher rates of virological failure in the age group of adolescents. And so assessing the resistance in the context of this treatment failure will provide really a clinical benefit in terms of improving outcomes and reduce mortality. As we have heard, AIDS-related deaths are on the rise. And so in Tanzania, the first surveillance was done in 2020, and it looked at acquired drug resistance. So we wanted to have a cross-sectional analysis to look at this special group in the sense that it's usually lumped in either pediatrics or others, and we don't see where the adolescents are featuring in this surveillance. So we nested this cross-sectional analysis in the main surveillance, whereby there were 36 facilities that provide care and treatment. They were chosen based on this two-stage cluster design sampling, and data was collected for 4 months, July through October. And the samples that were used were the DBS samples that were collected, and they were sent to British Columbia in Canada for viral testing as well as genotyping. And eventually we did use the Stanford HIV database algorithm to predict the resistance. So on the other side of the is the figure showing that we extracted the data from the comprehensive national surveillance. We excluded children 18 months to 9 years old, so as to get this 10 to 24 years, and also excluded the adults of 25 years and above. So we remained with 578, and we had to exclude 8 more because they had invalid results. So we're going to see the characteristics of 570 participants, and these are the baseline characteristics. We'll see more of adolescents, that were the majority, more than 90%, and fewer youth. And female were predominant in this data set. Most of them had primary education level, and majority, around 84%, were on INSTI-based ART regimen. So looking at the overall suppression as defined by viral load less than 1,000, they were around 88.8%. So the remaining 64 participants, that equates to 11%, had high viremia or non-viral suppression, and these 64 were genotyped, and we found prevalence of acquired drug resistance to be 71.9%. We were interested to look at the resistant patterns in terms of ARV classes, and as you can see the figures, the figure 1 and 2. The figure 1 shows the class on its own, and we see the predominant NNRTI, around 67%, followed by NRTI, 43%, and the rest were less than 10%. Interestingly was also to look at the dual classes that were either used in the past or will be used, NRTIs. We see NNRTIs and NRTI combination dual class resistance was at 40%, but at least the current NRTI and the PIs, as well as NRTI and the INSTIs, are less than 7% dual resistance. So this slide summarizes the clinical relevant mutations. We see the most frequent was the K103N, that was at 42.9%, followed by the M184V. But also of note, you see there are thymidine analog mutations, which were with the frequency of around 28%. Interestingly, we did not find K65R, despite that majority of the participants were on tenofovir-based regimen. And also, we see that there were emerging INSTI major mutations as listed on the slide. So we also wanted to look at which factors, and we listed a number of variables that we thought will be as associated with the development of drug resistance. But of note, we had the initial viral load test, or the first test that is done usually 6 months after ART initiation, according to our guidelines, was a significant factor that was associated with drug resistance. And also, male gender was also one of the factors, but this, when logistic regression was done, it was not statistically significant. So our key discussion points is that despite that more participants were on the Dolutegravir-based regimen, still the viral suppression was below the unit targets by that year, 2020, and even if we look at going forward to the 95 UNA's target. So this makes us to question and ask ourselves, are the existing youth-friendly services really catering for the clinical monitoring or even the monitoring the treatment outcomes? The high percentage, the prevalence of 70% also gives us the thinking to revise our guidelines in terms of high proportions of NRTIs, and this might be increasing the risk of INSTI monotherapy. And also the presence or existing of the terms reflecting that there was a prolonged kind of a treatment failure that went undetected. And this has an impact when we think of Zidovudine used in the second-line ART. But we also know that combination of 3 or more terms will cause cross-resistance and have a negative impact on tenofovir response. Of note is that we attribute the INSTI DRMs to be either they were archived before the DTG rollout, and then they were amplified when we had the transition. So in conclusion, this analysis shows that more than 1 in 10 of our adolescents and young adults have high viremia, and the high prevalence we've seen of ADR, drug resistance, which is acquired during treatment, plus the clinical relevant DRMs, it calls and wakes us up to address their prevention. We are all aware that there are prevention mechanisms to prevent acquired drug resistance. And so this makes us also to recommend to consider genotypic testing when we are switching the ARVs for this particular population, which is at high risk of developing treatment failure. It will give us a guidance on which NRTIs to use or recycle the effective NRTIs to improve viral suppression. And also we recommend the national programs to perform periodic analysis, much as now we are pediatric DTG10 is being rolled out to even the younger adolescents. We need to follow up the emerging INSTI mutations. And lastly also, we recommend the evaluation of the implementation of these youth-friendly services in terms of service delivery models, which are differentiated either at the facility in terms of multi-month prescription refills of ARV or the community refills. Are they implemented in such a way that they are going to give us the good results of the treatment outcome? Thank you so much for listening. Sorry, so I had to acknowledge the team from MUHAS, which led the national surveillance, the national hospital as well, and the National AIDS Control Program for allowing this work to be done by our university, and lastly, the Global Fund, which funded really the surveillance. Thank you for reminding me.